We're ready for you, Diksha.
Okay. All right. So I'm Diksha. I'm one of the fourth-year adult neurology residents, and today I'll be talking about review of neurometabolic tremors. So let's get started. The objectives with this talk are reviewing classification of tremors based on clinical exam, and then we'll move on to identification of the different types of neurometabolic tremors, and then understanding their individual pathophysiologies, diagnosis, and management. Most of this talk is based on a book chapter written by Dr. Peter Hedera and by myself, which is in print to be published later this summer in the book Mechanisms and Emerging Therapies in Tremor Disorders. And these are the topics that we will be covering in this talk. So just to go over the definition of a tremor really quickly, the International Parkinson Movement Disorder Society Task Force on Tremor defines it as an involuntary, rhythmic, oscillatory movement of a given body part. We can classify tremors based on the history obtained from the patient and then examining it at rest and then its change with posture, with intention, the different conditions that activate it, frequency, and topographical distribution. Tremors are different from other involuntary movements because they are so repetitive, stereotyped, and have a regular amplitude and frequency for the most part. And the positions that a tremor should be examined in, there are overall 5 positions, starting with in the resting position, so either in the lap or hands dangling off the side of the arms of a chair, and then with outstretched arms, where the hands are pronated and elbows are extended and fingers abducted, and then while performing a finger to nose test. Then additionally, we can test them where the hands are pronated with palms facing each other, dorsum of the hands facing each other, and then in a bat wing position. Based on the data we get from examining the tremor and from the history that we get, they can be broadly classified as postural, kinetic, resting, task-specific, and position-specific tremors. So why are we talking about this topic, and why are neurometabolic tremors important? So number one, because they are easily detectable by lab assays and originally stem from biochemical abnormalities. Number two, they have specific treatments that can mitigate the tremor instead of just being limited to symptomatic therapy of tremor. And number three, and probably the most important, is that learning about these tremors helps us diagnose them faster because a diagnostic delay may negatively impact prognosis. So broadly, we can classify neurometabolic tremor etiology into 5 divisions: organ dysfunction, endocrine abnormalities, electrolyte disturbances, inborn errors of metabolism, and drug and toxin induced. From these categories, the drug and toxin induced part I will cover just briefly, just in the interest of time. Here is a list of medications that may be implicated in tremor disorders, and that is why it's very important to review the medication list of patients when they initially present with tremors. So moving over to our different types of neurometabolic tremors, number one, hypoglycemia, which is very commonly encountered, defined as plasma glucose less than 70. It can occur with insulinomas, functional beta cell disorders, factitious hyperinsulinemia, or any defect in the glucose counterregulation pathways. Clinically, it's identified by what's known as the Whipple's triad with a low plasma glucose, and then clinical manifestations of hypoglycemia, which resolve with administration of glucose. Here we see an enhanced physiologic tremor. What that means is it's a symmetric tremor of low amplitude and high frequency, and testing of this condition is timed to the occurrence of symptoms, where we check the plasma glucose levels, and then management consists of treating the underlying condition. Next, we move on to hyperthyroidism, which occurs from endogenous or exogenous causes of excessive thyroid production or thyroid hormone production. And Graves' disease is the most common cause. It presents with ophthalmopathy and infiltrative dermopathy. This condition can A, exaggerate pre-existing tremors, and B, produce its own tremor, which is also seen in drug-induced thyrotoxicosis, as with amiodarone or lithium. The type of tremor we see in hyperthyroidism is the fine tremor with low amplitude and high frequency. This is also under the category of enhanced physiological tremor. It is symmetrically present in upper extremities, and testing consists of serum TSH level, free T3, T4. Other than this, we can do some imaging, a thyroid ultrasound, and radioactive iodine uptake studies, and we can also look for thyroid receptor antibodies. Management consists of thionamides if there's a normal to high RAI uptake, or treating the underlying cause if it is thyroiditis with a low RAI uptake. Then Pheochromocytoma, it's a catecholamine secreting tumor of the adrenal medulla. It presents with paroxysms of hypertension, headaches, sweating, and tachycardia. It can be associated with some familial disorders such as MEN2, RET mutation, or von Hippel-Lindau. The tremor is caused by a catecholamine excess, and a similar tremor is present in all epinephrine-producing neuroendocrine tumors. The tremor type here, again, is an enhanced physiologic type with low amplitude and high frequency. It's frequently associated with hypertension, which may be sustained or may be rapidly swinging. In addition, there may be hyperhidrosis, anxiety, palpitations, pallor, or nausea. Testing consists of checking blood levels of catecholamines and urine levels of catecholamines and metanephrines. And an abdominal imaging can be undertaken to localize the tremor. The ultimate surgery ultimate management is surgery, but we can also do genetic testing prior to this. Hepatic encephalopathy is a very commonly encountered condition. It is the neuropsychiatric complication of liver dysfunction, may occur from TIPS procedures or variceal bleeding. Encephalopathy-wise, it may range from subtle to overt. There may be insomnia and deficits in attention, reaction, or working memory. In addition, there may be disorientation or mood changes. All of this can be graded using the West Haven grading system. And systemically, there are classic signs such as jaundice, ascites, palmar erythema, edema, spider telangiectasis, and fetor hepaticus that clue us to the diagnosis. A very classical tremor called asterexis or flapping tremor is seen in this condition. It's also known as negative myoclonus, characterized by brief lapses in tone and maintained posture. It's most evident with outstretched and dorsiflexed hands. In addition to these coarse tremors, we may sometimes see chorioathetoid movements, and in severe hepatic dysfunction, a metabolic tremor, which is characterized by tremulousness, can be seen. It's important to note that in very severe hepatic encephalopathy, like grade 4, with comatose states, asterexis is usually absent. And other neurological issues that are seen with hepatic encephalopathy are bradykinesia, hyperreflexia, nystagmus, dysarthria, or ataxia. Testing consists of checking the liver biochemical and synthetic functions besides electrolyte levels. Brain imaging may sometimes show diffuse cerebral edema in severe cases, otherwise may reveal symmetric hyperintensity in the insula, thalamus, and posterior limb of internal capsule. It is also important to get an MRI in these cases to rule out alternative etiology. EEGs are abnormal, like we know, with diffuse dysfunction showing triphasic waves because of hyperammonemia. And management consists of essentially treating the precipitating cause, and medications that we commonly use are rifaximin, zinc, and lactulose. And in advanced cases, liver transplantation is warranted. Then hyponatremia, this is an acute and significant reduction in serum sodium, which causes a lowering of serum osmolality, which in turn causes cerebral edema. This can occur from renal failure, heart failure, liver failure, SIADH, endocrine dysfunction, or a high fluid diet. Usually manifests as headache, confusion, lethargy, and is life-threatening at levels below 120. And while sodium is not known to directly cause tremors, a rest tremor may be seen as a long-term sequela of extrapontine myelinolysis. This may be associated with Parkinsonian symptoms, masked faces, shuffling gait, and a pill-rolling tremor. And testing consists of serum and urine sodium and osmolality, TSH, morning cortisol in the serum, and management consists of treating the underlying cause, discontinuation of offending medications like thiazide loop diuretics, and fluid restriction. And goal correction would be 6 milliequivalents per liter per day. The MRI brain usually shows flare hyperintensity in the caudate bilaterally, putamen bilaterally, and thalami bilaterally, with sparing of the globus pallidus, as we can see here. Then hypomagnesemia generally occurs due to a low dietary intake, but can also occur in setting of refeeding syndrome, DKA, or increased renal or GI losses. We can also see this with chronic use of PPIs and alcohol. In some familial conditions, this is very commonly seen, such as Gitelman and Bartter syndrome, which are caused by recessive mutations in SLC1, 2, A3, and CLC and KB genes, respectively. This is also seen in East syndrome, which is an autosomal recessive disorder, which presents in infancy with epilepsy, ataxia, sensory neural deafness, and salt-losing tubulopathy, besides intellectual disability. Commonly, it can be asymptomatic or nonspecific symptom presentation, but occasionally we do see an action tremor with the upper and lower extremities and mandible. It can also have myoclonic jerks, fasciculation, and vertical downbeat nystagmus. All of these occur from hyperreactivity of the nervous system. And we can see the Schwastek and Trousseau sign in these pictures here. In extreme cases, it can cause tetany, seizures, and psychiatric disturbances and arrhythmias. In hypomagnesemia that occurs due to chronic renal failure, we can also see severe asterixis. And then management consists of IV magnesium supplementation and treatment of the underlying pathology. Then we move on to hypermanganesemia. So manganism results from changes in striatum or globus pallidus and substantia nigra. We see a lot of acquired causes in our daily practice with high dietary intake, from exposure to well water, from total parenteral nutrition and inhalational exposure. There can also be an occupational exposure in workers who work at steel or welding factories, and from exposure to a fungicide called Maynab. It commonly presents with asymmetric chorea with neurocognitive decline, and then inborn errors of manganese metabolism can be linked to these genes listed here. The homozygous deletion of SLC3810 will often produce hypermanganesemia with dystonia 1 called HMN-DYT1. In these pictures, we see that, so these are serial MRI scans over a 10-year follow-up from pre to post treatment and improvement of the changes through this time. So here we see in this condition a four-limbed dystonia, dysarthria, fine tremor, and rigidity. This is commonly seen in children, and in adults, this presents as Parkinsonism without tremor or dystonia that is not responsive to L-DOPA therapy. In biallelic pathogenic variants of SLC39A14, Parkinsonian features are seen, including a rest tremor. And MRIs will show symmetrical T1 hyperintensity in basal ganglia. Management consists of chelation therapy with EDTA and iron supplementation. Primary hyperparathyroidism, it can be sporadic or familial, and clinical manifestations include cognitive dysfunction, hypertension, ventricular hypertrophy, and osteitis fibrosa cystica with renal stones. Here we see a Parkinsonian tremor that is associated with cognitive decline and proximal muscle weakness. And testing consists of checking the serum calcium, PTH, 25-hydroxyvitamin D, and urine calcium. Mild diseases are just managed with observation, but in serious cases, we check for candidacy of surgery by the severity of renal and cardiac disease. Then moving on to hypoparathyroidism, which is a PTH deficiency resulting from hypocalcemia. In all of these cases, vitamin D should be excluded. And primary hypoparathyroidism commonly occurs from iatrogenic causes like neck surgery. And secondary hypoparathyroidism it occurs basically from anything that can cause hypercalcemia, and then there's feedback inhibition of PTH. So this presents with muscle cramps and neuromuscular irritability. We commonly see Parkinsonian signs, hypokinetic rigid syndrome, and a typical rest tremor. And as we can see on this in the images here, we also see intracranial calcification. The distribution of these calcifications is usually striato-palidodentate, but it may be more widespread than that. And then management consists of correcting hypocalcemia with calcium and vitamin D. And then the very commonly encountered vitamin B12 deficiency. B12 plays a crucial role in DNA synthesis and in myelination. We see neurologic manifestations at levels below 400, and common causes include poor absorption, dietary deficiency, and certain medications. It can also be seen in an inherited transcobalamin 2 deficiency. Involuntary movements range from chorea, tremor, myoclonus, dystonia, to Parkinsonism, and sometimes we see an orthostatic tremor. An infantile tremor syndrome is seen sometimes in infants who have dietary B12 deficiency. It presents with anemia, developmental regression, and failure to thrive, besides coarse tremors of the head and of distal extremities. Testing consists of checking hemoglobin, MCV, and B12, and management is with supplementation. Then we move on to Niemann-Pick type C. This is an autosomal recessive lysosomal storage disorder. 95% of patients have an NPC1 mutation and 5% have NPC2 mutation. In infants, we see hepatosplenomegaly, but in later onset, we see hypotonia, developmental delay, ataxia, vertical gaze palsy, and dystonia. Patients with ataxia may exhibit intention tremor, but in the juvenile and adult onset NPC, we can also see a cerebellar outflow tremor. Sometimes, so it's important to note that juvenile and adult onset NPC with neuropsychiatric symptoms is incorrectly attributed to neuroleptics because of the symptomatology, and this may delay diagnosis. So a heterozygous state in NPC may present with a postural and action arm tremor, and it may also present with extraocular abnormalities, REM behavior, and Parkinsonism. We test this with elevated plasma oxysterols and 7-ketocholesterol. and management is with miglustat therapy. Then we move on to Wilson's disease, which occurs from autosomal recessive mutation in ATP7B. It's a disruption of copper transport, which results in copper toxicity in the liver and CNS. Occurs mostly in the first to fifth decade, and there's a combination of early onset Parkinsonism, dystonia, and tremor. There's a very classic wing beating tremor, which is proximal, appears with semiflex outstretched arms, and the amplitude increases with longer posture holding. But besides this, a bilateral action tremor may also present. So we test this with plasma ceruloplasmin, which is below 20, and 24-hour urine copper, which is greater than 100. On slit lab exam, we can see Kaiser-Fleischer rings, and genetic testing can be confirmatory, and liver biopsy shows copper deposition. The image here shows Wilson's disease before and after treatment. It typically shows structural abnormalities in the basal ganglia, putamen, striatum, and globus pallidus. Sometimes we can see hyperintensity in the midbrain around the red nucleus, which is called a panda sign. Management consists of copper chelation, zinc salts, and then we can use baclofen, trihexyphenidyl, and levodopa for spasticity or extrapyramidal symptoms. And then in severe cases, liver transplantation is helpful. Next, we move to Segawa disease or Dopa-responsive dystonia. This is an autosomal dominant GTP cyclohydrolase-1 deficiency. It occurs in children aged 5 to 10, usually presents with a postural dystonia of lower extremities. Sometimes upper extremities or craniocervical regions may be involved, and it may also present with a high-frequency postural tremor, but this is usually seen beyond age 10. In adults, we see a hand tremor and gait abnormalities. The most characteristic feature of this disorder is a diurnal symptom fluctuation, where symptoms improve in the morning or after sleep. And testing is with low CSF homovinylic acid, biopterin, and neopterin levels with normal phenylalanine levels, and MRI imaging is normal. As the name suggests, treatment is levodopa therapy without a decarboxylase inhibitor. Ataxia with vitamin E deficiency. So this is vitamin E producing ataxia. Alpha tocopherol levels here are less than 0.5 milligram per deciliter and frequently occur secondary to fat malabsorption. But there can also be a mutation in the tocopherol transfer protein A or TTPA gene. It presents with ataxia, hyporeflexia, loss of proprioception, and vibration, and the phenotype can look like Friedreich's ataxia. We do see in this condition a side-to-side dystonic head tremor, but rarely it can present without ataxia, just with cervical dystonia and cognitive dysfunction. Treatment consists of lifelong oral supplementation, and then an isolated vitamin E deficiency that is occurring from other causes can produce large amplitude tremors of the limbs and the head that again improves with vitamin supplementation. Moving to Abetalipoproteinemia or Bassen-Kronzweig syndrome, this is a malabsorption syndrome in infancy that presents with diarrhea, failure to thrive, intention tremors, and ataxia. Here we see a complete absence of chylomicrons, VLDL and LDL, and symptoms are mostly occurring from an impaired vitamin E absorption and associated with developmental delay. Here in the picture, we see pigmentary retinal degeneration that commonly occurs, and on testing, we find a critically low cholesterol and triglycerides. We also see a wide base ataxia gait and proximal muscle weakness. and a mild intention tremor can be seen. Management consists of vitamin supplementation before 16 months of age to prevent long-term sequelae, and rarely can be associated with ileal adenocarcinoma and spinal cord glioblastoma. Next, we move on to Biotin and Thiamine-responsive basal ganglia disease, or BTBGD. This is a childhood disorder. It's autosomal recessive, occurring from an SLC19A3 mutation, which encodes a thiamine transporter 2. Now, this occurs in 3 distinct clinical forms. One presents in early infancy, then childhood and adulthood, out of which the childhood form is the commonest. It presents with ataxia, with myoclonic jerks, encephalopathy, seizures, rigidity, and dystonia. Testing consists of CSF levels of thiamine and lactic acid in blood. There's low CSF thiamine, and lactic acids are elevated in blood and urine organic acids are variable. However, the serum thiamine level is normal. Management includes early oral high-dose thiamine and biotin replacement, and MRI shows an increased signal intensity in bilateral caudate, putamen thalamus, which can sometimes extend into the brainstem, cortex, and cerebellum. Brain atrophy can also be seen, and it's important to note that mammillary body is not involved in this condition. And we need to suspect this disorder in all cases of recurrent unexplained encephalopathy in children that come to us because early treatment is important. Then we're looking at GLUT-1 deficiency, which occurs from SLC2A1 gene mutation. Here we see a dystonic tremor of limbs and voice. It also presents with epileptic seizures, ataxia, dysarthria, dyskinesia, spasticity, chorea, or myoclonus, can cause developmental delay, microcephaly, and abnormal eye movements, which resemble opsoclonus, and they can be accompanied by syndirectional head movements. It does worsen with fasting and exercise, and testing shows low CSF, glucose, and lactate. MRI brain in this disorder is typically normal, and management includes initiating ketogenic diet to provide an alternative energy source, and also we can use triheptanoin, which is a medium odd chain triglyceride. Cerebral folate deficiency. This is here we see cerebral folate receptor alpha, which transports 5-MTHF into the brain. 5-MTHF is a precursor of SAM, or S-adenosyl methionine, which is utilized in numerous pathways. So cerebral folate deficiency can occur from the receptor mutation, from autoantibodies against the receptor, and mitochondrial diseases. It can present as a tremor, developmental delay, ataxia, dyskinesia, and truncal hypotonia. We can also see epileptic seizures and drop attacks in this condition. It can also present with chronic antifolate and anticonvulsant use, and may coexist with Rett syndrome, with Kearns-Sayre syndrome, and dihydropteridine reductase deficiency. MRI brain typically shows leukodystrophy, and EEG shows a slow background. And testing will reveal a low CSF 5-MTHF. Management consists of high-dose folinic acid supplementation. Next, we come to Cerebrotendinous Xanthomatosis. This is an autosomal recessive lipid storage disease. It occurs from a deficiency of sterol 27 hydroxylase encoded by CYP27A1 gene. causes defective bile synthesis, and which in turn results to accumulation of cholestanol and cholesterol in CNS and other tissues. Classically presents with infantile diarrhea, with cataracts and tendon xanthomas, but can also present with neuropsychiatric symptoms and a tremor, which is either postural with Parkinsonism or cerebellar intention tremor. Testing consists of looking at plasma cholestanol, which is high, and a normal to low cholesterol with decreased deoxycholic acid. There's also increased bile alcohols in plasma and urine, and increased CSF cholestanol and apolipoprotein B. MRI, as we see here, can show T2 hyperintensity in the dentate nucleus. It can also show leukodystrophy. Management consists of CDCA supplementation. Next, we have Arginase-1 deficiency. Arginase, as you can see in the cycle, it catalyzes hydrolysis of arginine to ornithine, which is returned to the mitochondria for completion of the urea cycle. It's autosomal recessive in onset and seen to begin between ages 2 to 4 with neuropsychiatric symptoms. We can also see progressive spastic diplegia, developmental delay, seizures, short stature, and intellectual disability. As far as tremors go, here we can see a postural and cerebellar tremor with ataxia. And we tested at neonatal stage, and there we see an undetectable arginase activity in RBCs. There's also elevated plasma arginine and orotic acid and guanidine compounds in the urine. As far as imaging goes, it's mostly nonspecific with brain atrophy, but diffusion tensor imaging can show a nonspecific injury to the white matter tracts as well. Management consists of dietary restriction with reduction of protein and arginine, with treatment of infections and vitamin supplementation. And finally, we come to Biotinidase Deficiency. This causes accumulation products which include lactic acid, alanine, propionic acid, and methyl citrate. The BTD gene is located on chromosome 3p25 with autosomal recessive inheritance of this disorder. And the typical age of onset is 2 weeks to 2 years, and rarely it can show a delayed onset. The tremor we see can be rest or postural. It can also present with ataxia, dystonia, Parkinsonian rigidity, seizures, rash, a developmental delay, optic atrophy, and sensory neural hearing loss. Untreated symptoms can progress to metabolic decompensation, seizures, hypotonia, coma, or death. And testing consists of elevated organic and lactic acids, biocytin and ammonia with low biotin level. An MRI brain shows cerebral atrophy, ventriculomegaly, and basal ganglia calcification. We can also see T2 hyperintensities. A spinal cord involvement is seen in late onset disease, and management consists of newborn screening and prompt supplementation, which can rapidly reverse symptoms. These are my references. I can take questions now. All right, thank you guys.